Hello and welcome everybody to the first EFIC webinar that's going to be focused around International Nurses Day. So I'm really excited for this, and we've got a really lovely webinar planned in which we're going to celebrate all things nursing and all things paid nursing as well. So we've got a panel of three expert paid nurses, and they're going to talk about their career, their journey, and the nurses that have inspired them to where they've got to today. So I'm really looking forward to this. And I should say, hello and welcome. So my name is Martin. I am a nurse by background, and I work at the Royal Marsden in London. And my journey into pain has been very much around, I've been a clinical nurse specialist, and I've been a lead nurse for cancer-related pain as well. So, and I'm also involved in the EFIC pain nurse work group as well as some other hats with the Pain Nurse Network and chair of the Royal College of Nursing Pain and Palliative Care Forum. So that's where I'm coming from. So I'm a very strong advocate of all things pain nurses. So what we'll do is we're just waiting on our third panelist, but she should be with us very shortly. So my first question really is just for our current panelist to give us an overview of your route into pain nursing. Where did it all start for you? So Flick, I'm going to come to you first.
Good morning, everybody, or good afternoon indeed to our European counterparts. My name's Felicia Cox, and I too am a pain nurse, which is quite coincidental considering we're all pain nurses here. And I also am involved with the EFIC Pain Nurse Education Group. I'm the co-chair together with Professor Nadia Nessler. Nadia, we're hoping will be able to join us shortly. So my route into nursing was, I always wanted to be a nurse, but in fact, when I first qualified, I had such a positive experience in the operating theatre that I worked there for the first 7 years after registration. And then it just all of a sudden happened. I just became not necessarily bored, but actually was quite an insular experience. And there was a job advertised locally. It was to set up an acute pain service using audited education with some external funding. So I did this, and I was very lucky to have two postdoctoral nurses who supported me. So that was my route in. Anya, how did you become a pain nurse?
Yeah, hi to all. My name is Anya, and my way was not the maybe straight way into pain nursing, because first I started, my starting point was my nursing experience on a surgical ward. And there I realized that there was no special pain treatment for older patients, and I observed complications. So I started to be interested in pain. So I had the chance to have an international hospitation program, and there I could see that you can do other things with older people with pain. And later on, I worked on an acute geriatric rehabilitation ward. There I extended my knowledge, especially for older people's pain. During my bachelor's degree, I did the Bachelor on Nursing Education, and I just finished my master's of nursing science. There I deepened my pain knowledge, and I had different projects, student projects, where I evaluated the status of the pain. So I realized that there was an under treatment, because very often the intensity of pain is shown like 0, and the real status, there's a mismatch. So this is quite important for my current job as a practice developer. So I feed back to the nurses and educate them to be more sensible on the taking pain. So it's more general above all departments of our hospital. And I had a student project with my fellow student where we developed a special career profile for a community nurse, to going more forward and to implement academic competence in a community setting.
That's very interesting, because My work in the post-anesthesia care unit in the recovery was the thing that really interested me in pain, because here you are, you're acutely managing pain after surgery, and that just spiked my interest. You know, you thought you were doing a good job, but actually it wasn't until you started to learn more about pain. We had no experience in Australia of any undergraduate pain education, and that's often the way now, that compared to our veterinarian cousins who receive, you know, I think on average about 56 hours in undergraduate studies. We're lucky if we get 2 or 4 hours in the core curriculum for undergraduate students. So it's really interesting how we all have very varied routes into, you know, where we are today. I just think it's really fascinating, because here you were, you've been doing projects as a student and also supporting people, you know, who are students now. But this also prompted me to recognize that there was no standard. So I developed, with the help of many nurse advisors in the UK, the Knowledge and Skills Framework for the Royal College of Nursing. And so Martin, then when you became the chair of the Pain and Palliative Care Forum, that then led you to the next project. I'm sure everybody would be interested to learn more about that.
Yeah, so we then developed the UK career framework for pain nursing, and what we did with that is we took the essence of the knowledge and skills framework, and we then applied it to different routes into pain nursing, and which is quite nice today actually, because I think between us and when Nadja gets here, we cover a variety of those different routes into pain nursing. So it's looking at that from a clinical point of view, going down the specialist nurse route, a leadership point of view, if you become a lead nurse or a service manager, and then an education or a research aspect as well. So coming down to more of like a clinical academic role, or more of a traditional research professorship type academic role as well. So I think just listening to both of your journeys, it's fascinating, because we kind of cover all of them really. So the thing I find fascinating about pain nursing really is it's not just clinical, it's not just leadership, it's not just education, it's not just research. We're crossing the boundaries from all those different roles really. So, and I think it's really important that we recognize that, because sometimes we get a little bit caught on the hamster wheel of, I'm only in a clinical job, what impact can I make? But actually, you can make a really big difference. I mean, listening to your stories, audits, research, standards, that was your routine. And I'm sure at the time you didn't see yourselves as leaders or researchers. You saw it as I want to do the best for patient care. But actually, you're making a massive difference, not just to those patients, but to a much wider group of people as well, because you're sharing that learning, you're sharing your experience, and it's improving care on a much bigger level, really.
I think I was very blessed actually to have 2 postdoctoral candidates, both nurses, to support me. One of whom, Dr. Dee Burrows, has really influenced my career, and I think I was really lucky to have such fantastic career role models very early on in my career. There were a lot of nurses who were very academic, but actually were the ones that were changing practice. And Professor Kate Sears, who is still working to this day, was the only nurse on the 1990 document in the UK, which is called Pain After Surgery, which was a report from the College of Surgeons and the then Faculty of the Faculty of Anesthesia. And she was the one that was the only nurse who represented nursing and pain management nursing and all those spheres that, you know, the academic, the research, the clinical practice, the education. And she was able to promote the clinical nurse specialist role in the in-hospital setting. And there were standards set to say that actually every hospital that was undertaking acute pain or acute painful procedures or surgery should have a clinical nurse specialist. And look at us, here we are today. Martin is one of the founder members of the Pain Nurse Network, which is a free network. And here we are also leading the European diploma in pain management nursing, and the examinations will be held for the first time in 2 weeks' time in London, which is amazing. Also, what is fascinating for me is the number of nurses that are actively involved in not only EFIC work, but actually the work of the individual IS chapters, and also IS chapters as well. And to have Rianne van Berkel as a nurse chair of the acute pain SIG is amazing. So Nadia, I'm just wondering, did you have any particular mentors or people that guided you early in your career or even late into your career?
Yeah, I had colleagues and ward managers who influenced me, and with their professional experience, and especially it was my nursing director and my ward manager giving the opportunity to implement new ideas from which I brought from abroad. I went to with, as I said, from at the hospitation program. I had the chance to go to America, and there I saw other clinical roles we didn't had. So I had the great chance to bring back some ideas, and had the opportunity to realize a little bit of that. And at least it was my fellow student who opened up the complexity of pain in a new dimension for me, because we brought our different perspectives together. My perspective from the Bachelor of the Nursing Education, and her pain nurse perspective, where we reflected the current role of pain nurses. So we felt that this is a very good way to reflect our profile. What do nurses do? What competences do they have? And what responsibility do they take? And what could they do in their role? Or which career options there could be? You can, or we would like to develop and go further to new career options. So she really give my pain perspective a new dimension and a new way of thinking. And it was the contact and exchange with international nursing staff, international discussion, and interprofessional to discuss together with the German Pain Society, to have different professions and discuss nursing roles and profiles.
Thanks. I'm just thinking back to you, Martin. I've known you really, I think, since the advent of your career. Was there any one or two people that perhaps influenced you?
I'd have to say you, to be honest with you.
Oh.
'Cause, yeah, I'm gonna put you on the spot there. Because like I said, it was you were there at the very beginning. I remember my very first paying job and meeting you and the rest of the girls at the Brompton, and sort of being like, oh wow, meeting such knowledgeable, experienced pain nurses that are having such an impact. I found really inspirational. And then joining the London group, because education's always been a real passion of mine. So meeting people like Emma Briggs, just to really inspire me about the paths and the opportunities that were available to pain nursing and the impact you could have in practice at a much bigger level, really. So for me, when I get to come and do things like this, there's always that little bit of imposter syndrome, thinking, oh God, but Flick and Emma, and these were the people that I looked up to, but now I'm here with them. So it's nice to kind of come full circle in a way. But as you were both been saying, really, it's showing the potential and the possibilities for the role and where we can take it. And you look how far we've come in the last 5 years. You think about that, and since the 1990s, we've come such a long way. Now we've got the EFIC nursing exams. We've got our own stream on the EFIC Education Academy. It's fantastic. So it'd be really exciting to see where we go next, I think.
I agree. It is amazing when you reflect, you think, how on earth have I managed to achieve all of these things? I can't remember. I was applying for something. I can't honestly remember what it was. And I had to provide a curriculum vitae. I know it was to be a principal investigator on a research study. And I look back and I think, have I really published all of these documents? Have I really been included in all of these working parties? And to have this influence, here I was, when I first started way back in 1997. Martin, you make me sound so old. But just to think where I've come from, I was a nurse who qualified in a hospital setting with no undergraduate degree, ended up doing my master's, and now, I'm involved with so many different things. And I think, back to some of my you know, life-changing experiences are the ones that the Arabs would say it's kismet, it's fate. I applied to join the editorial board of the British, well, what was then Reviews in Pain, which was published by the British Pain Society. Imagine my surprise when I received a letter from the then president to say, congratulations on your co-appointment as joint editor. And this was not what I was expecting or not what I had applied for. So sometimes things just fall into your lap. So I ended up editing that journal for 14 years. But the influence that this has given me and the experience that I've been able to gain, but actually I gain, I think, the greatest joy in my role from supporting other people to share their work and supporting them in their early project work. Think about all the work that's going on with our undergraduate and postgraduate students and encourage them to disseminate. It's the same sometimes. You do feel there's so much work going on, but nobody thinks they're doing anything special. But they are doing really fantastic work that's really influencing patient-reported outcomes. And it's just that influence. We often think of just pain management nursing as being in hospital setting, but actually the majority of nursing occurs in community and in the home setting. So it's recognizing, I think, that for us, that sometimes we tend to focus on the hospital setting when in fact we should be looking more broadly. What can we do as specialist nurses to influence what's happening in patient care in the community with those painful leg ulcer dressings, with the patients who have joint pain on mobilization? There's so much for us to do. And what I love is the different career paths that we've all taken. You know, if you'd asked me 20 years ago, did I think I'd be doing this today? Absolutely not. So here we are, the day after Nurses Day, and it's just wonderful to have so many people that are so enthused about nursing. But if only we could change the frequency of pain assessment on the wards or in the home setting, and actually getting nurses and other healthcare workers to recognise that we should be measuring the impact of any intervention that we do. But sometimes we just see that as perhaps, you know, a step too far. So that would, you know, be something I'd be really keen on doing and supporting going forward.
I think it's one of those, I hear this quite a lot really. It's the recognition, oh, nobody will be interested in the small audit I'm doing, or nobody will be bothered about an article on this because it's, you know, it's only me, it's only my work. But actually you just never know really. I remember the very first poster I submitted, I thought nobody would be interested in the slightest. It was an audit looking at the compliance of PC and epidural observations. So were they doing the correct observations on people with patient-controlled analgesia and those who'd had an epidural removed? And obviously they hadn't, which was fine. But with a bit of education, I was able to show that there was improvement. And I took that to an oncology conference. I thought, you know what, nobody's going to be interested. It's just my tiny pain audit. But you know, here that was my first publication. I got an award for it because of the presentation I got to do. It just opened up so many doors. So I would always say to people, never underestimate the change that you can make, because people will be interested in the things that you do every day. And it's often the simplest things that will make the biggest impact as well. So don't try and do something big, fancy RCT. You know, do something at the bedside. You know, can you improve pain assessment at the bedside? That will have a massive impact on care, well beyond you could ever believe. So we've gone a little bit off piece from the questions, but it's fine because we're having a good chat, really. I suppose just to circle it back a little bit, what one piece of advice would you give then to somebody thinking about moving into a career, a pain nurse role? Anya, I'll come to you first.
I think it's a great chance for us, especially the community health a setting where we can settle the pain nurse role more, because I can observe that patients come to a hospital because they are undertreated quite often, and this is the reason why they come to hospital. So for me, there's the vision that we can build like a bridge and think across the barriers we have sometimes, because we have different systems. So bringing this together, there's a great chance to raise awareness to the topic of pain management and implement new nursing career profiles to bring maybe the advanced practitioners into the community setting for long-term care, for example, or into the interdisciplinary multimodal pain therapy. I think even in the setting of community, there the nurses are the ones who get the first information and can collect and bring them to the therapy, to the hospital. So you're right that not only looking at the hospital, it's the way to improve patients' outcome. It's more looking all over the structures and be creative to bring expertise where the need is and the origin of the reason which bring the patient to the hospital.
I don't think I could narrow it down, so I'm interested in so many things because we as pain nurses have the ability to really change practice. I think medication safety might be the one thing, but also along with pain assessment and recognizing very early on that often you don't need to undertake a structured pain assessment. It's the words that patients use and the area that they indicate that's most likely, will give you the most likely reason for explanation for their pain. But actually, if I'm thinking about patients coming into hospital to have surgery, it's about what we do in the pre-assessment clinic really can influence, patient. There will be undertaking familiarization with whichever pain assessment tool we'll be using. We need to recognize those patients that are at higher risk of perhaps greater pain after surgery or the risk of persistent post-surgical pain, and also recognizing those patients that are on high dose opioids and gabapentinoids, etc., and just trying to influence their patient pathway, making everybody else aware that there might be some risk associated with withdrawal, and agreeing with the patient and their carer some management plan, and also setting expectations about the anticipated hospital length of stay, what analgesia will be provided both in the in-hospital setting, but actually what patients can do themselves to promote, self-management, both in the hospital setting and also at home. Martin, what are your thoughts?
Yeah, it's interesting. It's interesting listening to this. For me, what this sounds like is it's the essence of really good nursing care, really, isn't it? If you strip it all the way back, what we're really doing is we're showing our ability to be really good communicators that are providing really holistic care to that person. I was speaking to some colleagues last week about this, and what was it they said is that we were asking, what do you think you do as a nurse? What is the role of the nurse? And you think, well, we just get stuck in, really. We just we do a bit of everything. It's about, we fill in all the gaps. And you think, well, yeah, I suppose in a way that's kind of what you do, really. You're with that person in that moment and in time that's, their whole world has been turned upside down. No matter, you don't know what's brought them into hospital or what's happened in the community with them. And you're there just to sort of you're with them in that moment of uncertainty, in that moment of crisis and distress, really. And yes, we can talk about all the advanced practice skills, we can do all these fancy assessments and prescribe all these medicines, but actually the essence of all of this is having a really, really good holistic assessment of that person. What impact is it having on them at that moment in time? And what do they need from us to be able to help them through that? Is that self-management? Is it getting the family involved? What is it that we can do to help move them through that episode of care, really? And I think for me, that's sometimes the thing that gets a little bit lost whenever we're celebrating anything about nursing roles, is that, yeah, we can do all the fancy stuff now as well, but actually at the essence of it, we're the advocates for that person, and we're the ones providing that really good holistic care. Oh, Nadja has arrived. Wonderful.
Hi all together. Hi, Flick. I'm so sorry to hear you. from you.
That's okay. We've just been having a nice chat actually about our careers, the people that have influenced us, and we're just talking about what's the one thing perhaps that is your real particular interest, or the thing that you'd like to change in clinical practice, or in your role as an educator stroke researcher.
What I want to change.
Yeah, just one or two things, not the whole world.
Yeah. The whole world would be very nice. Yeah. Okay.
Or Nigel, I wonder if it'd be helpful to kind of come back a little bit. So the other people I've introduced were their backgrounds, how they got into pain nurse, and I wonder if you could give us just a brief overview of how you've gotten to where you are now.
You want me to explain it now?
Yeah, yes, please. Yeah.
Okay, so I want to give a short introduction that I was a pain nurse at first after I studied nursing, and then I become a researcher in a clinical surrounding in a big German project called Pain Free Hospital. And after that, I go to the university as a researcher, and also their pain was and is a main topic of my research and what I'm teaching and thinking about. And since last year, I'm a professor for nursing science and advanced nursing practice. And therefore, I want to promote the roles of APNs in pain management in Germany as well as in Austria, because we have pain experts in Germany as well as in Austria, but there are no academic trained nurses.
Gosh, I mean, if you'd highlight really that Nadja recently got her professorship, which is a fantastic achievement, not just for you, but for pain nursing, because it's excellent to see we've got another nursing professor flying the flag for specialist pain practice, which is always excellent.
I think it's really interesting how we've all come together. You know, we've with the EFIC group, is that we have such interesting but representative sample of nurses. We have you, Nadia, who's leading the way in education and research. Martin, who's on his he's really interested in education, but actually researching cancer-related pain. I come from very much a perioperative setting, and whereas Rian is interested in persistent post-surgical pain from an epidemiological perspective, and we have other educators and people working in clinical practice. So it's fantastic to have such a wide group. But I never would have considered pain nursing as a career when I was a student nurse.
No,
no, it
no.
never entered my mind, because if I thought about specialist nurses, I thought about there were nurses for stoma care and some for wound care. No such thing as a pain specialist nurse. So it's amazing. Here we are. We have 450 nurses who are pain specialist nurses in our free to join pain nurse network, all interested in one thing, and that is the patient. They're not interested really in career progression, but they're interested in improving the outcomes of patients and the whole patient experience. And Martin was just saying about how we as nurses are communicators, but we look as well, don't we? We have our initial assessment is done on seeing the patient face to face. When we see them, we can see exactly, are they disheveled? Are they just lying in bed? Do they look frail? Have they been eating? What's their dentition like, etc.? And we can tell that. I've done some outreach events recently, and you can tell those people, you know, where you're standing at a stall, where you've got, you know, a big banner saying pain management, come and chat with us. And you can see the people that walk past, look, and then they'll walk past again and have another look. So pain is really highly prevalent in our communities. 70% of people present to the emergency or to the GP, as Anya was saying, and it is one of those long-term conditions that is not visible, but actually we do an amazing job.
Yeah. As I started in Germany in the pain field in 2000, there were no pain experts no nursing pain experts in Germany or in Austria. And it was only a field for doctors and for psychologists, and nurses did not think about that it is also necessary for them to think about pain and how they can manage pain when they are working with the patients and when they care for patients. And then we started to develop the nursing expert standard, we called it in Germany, for pain management in nursing. And that was the first time we thought about what is necessary for nurses to know about pain and pain management, and how we can, or what can we do for them that the whole phenomenon, pain, is managed very well. And I know that we had trainings for about 20,000 nurses in Germany. They came from Germany as well as from Austria and from Switzerland, but the most are from Germany. But not all are very interested in a pain management career, but we have experts about pain and pain management in the different hospitals, as well as in nursing homes or in the home care area. And I think that is very, very important. And also we have some who are interested now to develop a nursing career in pain and pain management, and that is very fantastic.
Yeah, I mean, it always fascinates me that we can pretty much guarantee everybody's going to get pain at some point in their life. Whether it be chronic, whether it be acute, whether it be stubbing your toe, you're going to experience it at some point.
Yeah.
But how we deal with it in practice and sort of this, it becomes a bit of a hidden symptom in a way, where we know you're going to get it, but we don't really want to talk about it. So it's really good to see that, you know, the role of that specialist nurse is really coming into its own now. It's taken a long time. We've still got a long way to go, but we are getting there. So it's good that we can really sort of ensure that all nurses know that, yeah, you can do something about it. You can do a really good assessment, and there are people out there that can help with the more complex side of things. But pain is everybody's problem, really, and we should be coming together to help address it. Yeah.
It's interesting because I did many years ago, 2005, a long time ago, a research study looking at the persistent pain after surgery, after thoracotomy. And at that time, I went and sat in some thoracic surgical clinics, so some lung cancer clinics, and none of the surgeons even asked the patients after surgery, did they have pain? And I asked them all individually at the end of each of their clinics, you didn't mention pain at all. And that's the subject of our study. They just said, well, if the patient said yes, what am I going to do? I'm a surgeon. I don't know how to manage pain. So often it was under-recognized by our surgical colleagues, or a subject, indeed, Martin, that you'd mentioned, that they didn't want to ask, because if the patient, had a positive answer, yes, I have pain, what are you going to do about it? And the surgeon just felt unhelpful. But now at least they know that they can signpost, and I regularly receive patients telephone calls and also emails from the surgeons, or just tagged into letters saying, can you contact this patient? So we've had some movement there, but I think we've still got some movement in some under-recognized specialities as well. But we really have influenced practice and continue to influence practice.
My point of view, it's very important to have the specialized services like acute pain service on one hand, but on the other hand, Martin said to see patient holistic, or there has to be a sensibilization for the nursing team, basically, and we need some people in the interface, like if we see the different competence or the competence model and the curriculum of the German Pain Society, there is the qualification mix there needs also someone who implements the guidelines with the newest evidence and bring it to all the other nurses to have this basic knowledge and to be the interface to this specific pain service team. Because otherwise I see there's like a disconnect, and it's getting quite functional if we don't have someone in between connecting all this and bringing back the education to the team. And so in my point of view, we come from quite a traditional role where every nurse did the same thing, but we have pain nurses in the department teams, and they sometimes don't have specific task to do. So I think we should use all this knowledge in these teams, what they bring together with their qualification, and bring together and connect this to come to a better outcome for the patients.
Yeah, fantastic. I mean, it's both like we were saying earlier on, really around that, if we look at undergraduate education for nurses specifically, and this is in the UK, and there's also some paper across Europe where it's not really high on the priority in the curricula. The hours of practice you'll get as a student nurse will be much less compared to that of a vet or a medic. And so when you've got, we're having to do a little bit of a catching up, really. So when you've got that specialist pain nurse within the hospital, they are the fountain of all knowledge. So they should be using that to sort of empower the other nurses in the wards with some of that knowledge and give them the confidence to be able to go away and do a good pain assessment, or flag things that may not seem quite right, because we've all seen the slightly rogue prescription or the near miss drug error when it comes to pain medicines, or the patient who is not getting access to the medicines that they need because that pain nurse can't be everywhere. They can't be all things to all people. So we need to ensure that we've got the wider nursing workforce as well, that they're able to do the same thing.
I think sometimes, though, we're at risk because we're super specialists, that actually perhaps the nurses are becoming de-skilled. And so I think it's really important for us to embed ourselves in clinical teams, not just to provide the education, but actually ensure that our nurses are undertaking audit themselves of clinical practice. That's the only way really to change practice, is to measure against the benchmarks and to show not necessarily any deficiencies, but actually applaud where people are doing fantastic pain assessments and recognizing early persistent post-surgical pain or patients that are at high risk. So we have many, many roles to play, many, many hats to wear.
Yeah, so the idea of we're everywhere at once. We're the researcher, we're the educator, we're the clinical expert. Yeah.
I think, yeah. And as you said, it is very important that we have different roles. And I think we need the nursing research. And maybe sometimes we are only focused on an interprofessional or interdisciplinary way to work and to study and so on. But I think it's also important that we have our own research, because only when we know what is our possibility and our task and how can we do something, then we can put it together with all the other disciplines to a better one. And therefore, I think we need also nursing experts who make research, because I think it's a nursing topic to have a look on the specific needs for care for people, for example, with dementia or something like that. That is a really specialized topic where nurses have their own tasks and their own perspective. And this perspective we have to study and to look how we can care for these people. and how what we can put into the interdisciplinary pain management.
It's interesting that you mentioned pain in older people, because some pain nurses have really led the way. I'm thinking about Keela Herr and also Pat Schofield, both really great advocates of us pain or upskilling nurses in residential settings, in older people's homes, in the community, to recognise the need to assess pain, and also that sometimes what we should be if patients can't self-report, then it's behaviors. So to have nurses leading, validated pain assessment tools rather than psychologists is absolutely fantastic. And if we look at the influence that the older people seek of IASP and our regional pain societies, they'll mostly be led by nurses, because we have, as you said, Nadia, a vested interest not only in educating other nurses, but actually researching where are the gaps in practice. And it's nice actually that there are some new dimensions of this, the use of video recognition, of facial screening, using apps, etc. So nurses are leading at the forefront of assessment.
It's just making sure you're celebrating that. So we always come back to that. Whatever you do every day, doesn't matter how small it is, celebrate it, share it, join in with these bigger organizations, whether it be the pain societies where you're based, or the Pain Nurse Network, or with EFIC. It's all about celebrating the contribution and the work that you do, because it is going to raise the profile of pain nurse, and it's going to show the value of what we bring every day to clinical practice. And the value that we bring is it's going to make a big difference on that. Even if it's on a small scale, it's still a big difference. If you're helping a small group of patients, you're having a positive impact on their quality of life, and that should be celebrated, really. And you can do that in many ways with the EFIC diploma. So that's a recognition of you as a specialist pain nurse. So that's a nice way to celebrate you as an individual. But then attending things like the Education Summit, learning from others, giving you that inspiration and confidence to say, yep, I am an expert, I do know what I'm doing, and I am making a difference in practice.
And also, let us not forget that abstracts are open for posters for EFIC 2025. So who fancies joining us in Lyon? We nurses, we have some refresher courses at that event. So we have guaranteed nursing contribution to the scientific program. But this is your chance, actually, to share your work that you're doing. If you need help from us, just contact us via EFIC. We are very keen to support nurses, perhaps early in your career, or to help you with, when you're thinking about your ideas, how to share them. So getting, your data together is great, but actually just please share your ideas. We all learn from one another, and there's also an opportunity during the EFIC meeting for us nurses to get together to share our own experiences on our nursing pathways. So please don't be shy, share your work. And if you're interested in writing for publication as well, there's lots of opportunities, across Europe. Think about the publications of your national society, whether that's Schmerz or perhaps British Journal of Pain or some of the other august journals. Doesn't have to be the European Journal of Pain. There are other opportunities. You can also help us if you're interested in writing a blog, because we're aiming to generate content from nurses working in pain. Yeah, so just please get in touch with us.
You never know, you could be on a webinar like this in the future talking about your specialist area of interest or practice. I mean, the possibilities are endless. I think we're here to support, really. So if we can do that, please just let us know. You never know what opportunities may come from or what doors may be open. Yeah. Well, it doesn't look like there's any questions coming through from the attendees, which is absolutely fine. So I'll say thank you very much to the panel. It's been really enjoyable. It's just been lovely chatting with you about all things pain nursing, and I hope you found that interesting. And just to reiterate some of the points, if you do have any questions after this, or if we can be of any advice or support at all, please do reach out to us via EFIC. And we hope you've all had a lovely International Nurses Day.
Thank you so much.